What if I told you there's a test that can predict with 98% accuracy that a heart attack will happen? Believe it or not, there is. The test is called CIMT. And get ready for the geeky part. That stands for Carotid Intima Media Thickness Test. There was a landmark study called the Cafe to Cave study, and it showed how from a group of people, over 10,000 people, that they followed over a 10-year period, 98% that had significant levels of arterial plaque in their carotids had events. So Ariana Feldberg is here to discuss how to access this test and how to review it, what to think about it, and how to manage it. Unfortunately, we've already got some comments. I can't help but make a comment about it. One of the questions, JMK is saying, well, what portion of cardiologists understand this? I would estimate less than 2%. Unfortunately, even at the low carb conference, there are cardiologists there that know the low carb space. I remember one of them said, "Oh, wait a minute. I recognize you. You're the guy that does that. What was that study? What was that study?" And I said, I knew where he was going, CIMT. And you could sort of see the face relax back into Anyhow, not going to go any further than that. I was not in a mode to get into a debate at that point. But one of the things that I've found out since then is that the American Heart Association Standards Committee has added CIMT. Before they didn't have calcium score, they didn't have CIMT. Now they have both. So unfortunately, cardiologists are humans too. And it's like six blind men and the elephant. We all see different things. It's much easier to get it right when we're describing what we're seeing. But when we're assuming that the other person that sees something else is wrong, that's where we need to be careful. Well, if I'm being a little bit obtuse with my analogies, let me stop for a minute and get into discussion with Ariana. Ariana, are you available?
Brewer, good morning.
How are you?
I'm good. How about yourself?
I'm doing very well. Glad to have you here. Glad to get started on CIMT. We've got a lot of folks who've been here. I'm sure many of them have been here before and understand CIMT, at least have some awareness. But there's a lot of people that have not been here before. So I think what we probably should do is start off at least with some of the basics and then go deeper.
Okay. So I'm a registered vascular specialist. I'm also certified to do CIMT scans. And what CIMT stands for, as Dr. Brewer said earlier, is carotid intima media thickness. So what it is it's an ultrasound, and it's on both sides of your neck. It's completely safe to do for everybody. And what we're looking at, which is different from a lot of what other people think they're getting done. Oftentimes my patients come to me and they say, "Oh, I've had this done before, and everything was good." The challenge is sometimes patients get it confused with a Doppler. And what a Doppler does is it looks at your blood flow. And unfortunately, Dopplers are not terribly accurate in predicting your risk factors for heart attacks and strokes. The CIMT, on the other hand, is exceptionally accurate in predicting your risk. It's 98.6% accurate in predicting your risk for heart attack or stroke prior to them happening. And as Dr. Brewer had mentioned in the very opening, there was a landmark study done back in the early 2000s, the Cafe Cave study, where they followed 10,000 people for 10 years. And these folks agreed that regardless of what their findings were on their CIMT test, they would not seek treatment. So, sorry, go ahead.
As Jesus promised, I would probably interrupt. And I'm going to go ahead and interrupt and reel us backwards just a few seconds.
Yep.
You mentioned Doppler. Let me take a minute and describe what Doppler is. We get a lot of people that come in that have Doppler only studies, and we'll also say that's a flow study. Now, here's what it is. You've seen Doppler on weather, and Doppler uses the same kind of technology that submarines use. It sends out a vibration, and then it reads the what it gets in terms of bounce back from that. It's basically looking at flow only. And what's become very clear from the Cafe de Cave study, and Jesus hates it when I quote the Princeton study because it's hard for him to find, but the Princeton Prevention Center has said the same thing. It's not flow. Here's the problem with stress tests. You only get a positive stress test if you have 50% or more blockage in flow. And that's just common sense. That's what most people assume, including the vast majority of cardiologists. The reality, though, is that's not how heart attacks and strokes happen. It's not the flow is blocked off by fat lining the inside of the artery wall. You only have to have a tiny amount of plaque to have an event. And it's because it's an inflammation event process, not that slow squeezing off. So, as they've said at the Princeton Prevention Study, over 2/3 of people that have a heart attack or stroke have not had a 50% impact on their flow yet. They had far less impact on their flow. And again, that's exactly what the Cafe de Caves study showed. So that's why Ariana was saying, unfortunately, we get too many people that assume this is just ultrasound and we're looking for the Doppler. We're looking for flow impact. We're not looking for a flow study. We're looking for small amounts of plaque. Thank you for your patience. I had to interject.
No worries. So let me clarify to you a little bit more about what Dr. Brewer is saying of what actually a CIMT is and why it's so superior. So the CIMT looks at the lining of the wall. It's one cell layer thick. And what the ultrasound does is it measures that thickness of that wall. And the CIMT test looks for inflammation, which is the precursor to plaque. And the CIMT is also the only test that can pick up soft plaque. And I'll tell you a little bit more about my story in a little while, but soft plaque is the most dangerous kind of plaque because it's unstable. And like what Dr. Brewer was saying is oftentimes people think that what causes a heart attack or stroke is the analogy that I kind of like to explain to my patients because I think they kind of get it. And I believe this too before I switched careers and learned how to do this. I always thought that heart attacks and strokes were caused from that blockage. Like you put too much garbage down the kitchen sink and now it won't drain. So now you have a heart attack. That's not actually what most often happens. So when people have a heart attack or stroke, most often what happens is there's a soft plaque and it's just sitting in that lining of the wall of your carotid artery. And basically all plaque is, by the way, is a large inflammation. So that inflammation reaches a certain size and it qualifies as a plaque. And for the cardiorisk CIMT test, it's a 1.3 millimeters in size or larger, makes it an actual plaque. And so it's sitting in that one cell thick lining wall of your carotid artery. And for whatever reason, if you think of it like a pimple, it pops and it tears through the lining of the wall of your artery and your body goes, oh my gosh, I'm bleeding. And it's literally the same response that you get when you cut your skin. It's the same chemicals. It's the same response. I'm sure Dr. Brewer and Heather can probably get to the chemistry of how this all happens with reactions, but we'll stick to the basics here. So your body's thinking, oh my gosh, I'm bleeding. There's a hole in my wall of my artery. I have to stop this bleed. And your body sends out this reaction to stop the bleeding, same as you cut your skin. Now, it's a good thing when you cut your skin because nobody wants to bleed to death from a paper cut. That would be catastrophic. I would have been dead a long time ago because I'm a klutz. Not so good when it happens in the lining of the wall of your artery, because within about 4 seconds, your body does too good of a job and it stops all the blood flow. So that's what causes the heart attack or stroke. So the CIMT test is far superior from a Doppler because it can pick up those soft plaques, and it's the only test that can. Even CAC scores MISC soft plaque. It's right in the name of the test. It's a coronary artery calcium score. And if your plaque is soft, there's no calcium yet. So you're going to pass that test with flying colors and think that you're good. And you may be, but you may not be. The CIMT test will pick up the soft plaque, which is the most dangerous. And it'll also pick up any inflammation. And since inflammation is the precursor to plaque, if we can stop it at an earlier time before it even reaches a plaque size, your health is that much better. What's up on the screen here is also the other ones talking about the Honda study. And that's what I'm talking about is, so if you have plaque, does it matter, if it's soft, if it's squishy, if it's hard, does it matter? Yes. The answer is yes. Calcified plaque is very stable, and the chances of it rupturing or causing a heart attack or stroke is very, very low. Whereas the soft, squishy ones, if you think of it like a pimple on your face, as gross as that sounds, you don't want those pimples to pop, because as soon as they do, that's what causes a heart attack or stroke. So these two studies that are up on the screen right now are the two that are really kind of nail home and drive home the importance of CIMT tests and why it's so different from a Doppler. Doppler won't look at plaque at all. It'll just look to see, like Dr. Brewer said, if you have a blockage that's greater than 50%. But the challenge is 85% of people that have a heart attack or stroke are less than 50% blocked. So if you look at it that way, we're damning 85% of the population to go ahead and have your heart attack or stroke. And if you survive it, then we'll help you. I don't like those odds. So this test totally flips that around and picks up 98.6% of the folks that are at risk of having a heart attack or stroke. So do you want to click to the next slide, Dr. Vega? All right, so it's 98.6% accurate in predicting a risk for heart attack or stroke. And this is the best part. It's painless. It's non-invasive. There's no needles. There's no disrobing. There's no radiation. It's safe for everybody. There's no prescription needed by your physician. If you want to have a CIMT test done, you just go get it done. You don't have to argue with your PCP or try to get an appointment to get a referral or see if somebody's in network. You don't have to do any of that. You just go get your CIMT test done. And the one thing about it that's really great is you just get to lay there for 20 minutes and I get to do the rest. You get to relax and I do all the work. There was an interesting study that I just read lately that they were actually doing CIMT tests on newborn infants the moms were had diagnosed gestational diabetes, and they wanted to see if that gestational diabetes had any impact on the newborn CIMT levels. They were still in the process, so I haven't seen the results yet, unless Dr. Vega, who's like a walking encyclopedia, might know the answer to that. But as far as I know, I haven't seen the results of that study yet. But it's just proving my point that it's absolutely safe for everybody because there's no needles, there's no disrobing, there's no radiation, and it's painless. Safe for everybody. All right, next one, Dr. Vega, please. So I've been doing CIMT scans for a while now, and this was a pie chart that definitely grabbed my attention. I do not see individual patient results because I'm not your doctor and it's none of my beeswax, but I do get to see the aggregate data so that I can keep track of the patients that need to be rescanned. If you have findings, they recommend that you get rescreened every year. So I do get the aggregate data of, red, yellow, green, and that sort of thing of all the patients that I've scanned. And this literally shocked me. Of the patients that I've scanned over the last 6 years now, a total of 85% of the people that I scanned were at higher risk. So a little more than 65% were in the red. About 21% were in the yellow, so also an increased risk. And only 13% of the people that I scanned were in the green. So that's shocking to me. And so that means that no wonder why heart attacks and strokes are so predominant, because 85% of us are walking around with risk factors having no clue. Unfortunately, when you have a heart attack or stroke, there's often no warning symptoms. There's no indication that something's going wrong. Usually the first actual problem is you're having the actual event. So it's not like you wake up in the morning and you're like, oh, I'm going to call into, sick to work today. I feel a stroke coming on, like, oh, I don't feel so good. unfortunately, that's not what happens. Usually there's absolutely no warning or indication that something's going wrong until you're actually having the event.
So
So,
Ariana, so a
yes,
couple of, let me interrupt again
yep.
with a couple of definitions. When you say 65% look like they have high risk, how do you define high risk? Presence of plaque or presence of soft plaque?
Presence of plaque, period. Because
Okay.
according to CardioRisk, who's the industry gold standard and who does all of my reads for me, the simple existence of plaque puts you in a higher risk bracket than for someone that has no plaque. So the ideal would be that you have no plaque and you have no inflammation. But let's be honest, life happens, and that doesn't, that doesn't paint the picture for most of us. And that's why there's only 13% of the people that are in completely low risk, because those are the folks that have no plaque whatsoever. So as soon as you have any plaque whatsoever, it automatically bumps you up into a higher risk bracket. However, having said that, just because you're in a higher risk bracket doesn't mean that you're going to have a heart attack or stroke. So if you get your CIMT result back and you're like, oh my God, I'm in the red, I'm going to freak out, I'm dying. No, you're not. The most important part is to then look at what kind of plaque do you have. So if there is plaque, you don't need to panic. Take a deep breath. Stress is bad for your cardiovascular health to begin with. And don't panic. It's all fixable. So 100% of atherosclerotic events, so heart attacks and strokes that are caused from these plaques popping, 100% of them are avoidable. You just have to know there's a problem in order to fix it. So even if you're in the red because you have a plaque in your finding and you're like, oh my gosh, that's it. I have to call the ER. The ambulance is on its way. I have to rush to the hospital because, heart attack or stroke is imminent. No. Take a second, take a deep breath, and look at the next section down in your report in the comment section. And this is the part that if you have a CardioRisk CIMT test done, please look in the little teeny tiny box underneath the red, yellow, and green. This comes color coded, but in that tiny little box that says comments, any measurement that's over 1.3 millimeters or larger, so that'll make it qualify as a plaque, as you remember me talking about earlier, and there'll be a letter after it. It'll say S as in Sam, which stands for soft, H is in heterogeneous, which is sort of a mixture of the two, and E is an echogenic. And those are the ones that are completely calcified and like a boulder. The chances of those rupturing are very, very low. If you have a finding that says soft plaque, then yes, you are at a much higher risk bracket. And that would be something that if it was me, I would definitely want to go see a cardiologist. And I'll actually tell you about myself. When so this is career number 3 for me. I switched to doing ultrasounds and doing CIMT scans in 2019, just prior to the pandemic. Great timing. But had I not switched careers and gone back to school to learn how to do this, I personally would have been a statistic. I would have been one of those people that just randomly dropped dead for no apparent reason. I grew up a vegetarian. I grew up an athlete. I have zero family history, which is pretty rare in today's day and age. Like no one in my family has ever actually had a heart attack or a stroke or passed away from a heart attack or stroke. I had just gone through a whole battery of tests to be a certified scuba diver for the state of Florida. So EKGs, echocardiograms, stress tests, pulmonary function, you name it, I had them all. And I passed them all with flying colors. So when I went back to school to learn how to do this and we were practicing on each other, I jumped up on the table to be the guinea pig thinking that I'm going to be good. Like all the doctors have always told me that I'm super healthy, like low blood pressure, great cholesterol. Like I am not someone that should be at risk. So I jumped up on the table being little Miss Cocky and arrogant. And I was like, I'm going to be one of the people in the green. I'm going to be one of those rare 13%ers. And the woman that was practicing on me all of a sudden kind of got very quiet and her face got a little white. And she goes, Todd? And she said it just like that with this horrible trepidation. And she calls over Dr. Todd Eldridge, who is the founder of CardioRisk, who's doing the certification. And Todd comes over and Todd grabs the transducer and does what Todd does. He's been doing this for like ever. And he's like, doing Todd things. And Todd goes, You also don't ever want to hear Todd say, when he has his transducer on your neck. That's sort of like a dentist saying, oops, no good could come of that. So sure enough, they found one of the really dangerous soft squishy plaques on my right carotid artery that had an 85% chance of killing me by the time I was 50 or causing a stroke. So someone would have to change my diapers, which for me, I think would be worse. No, thank you. So I was shocked. I was 42 at the time. And like I said, everybody had always told me that I was a healthy individual. And that's what I'd believed because that's what all of the doctors had always told me, blood work, etc. So at that point, I became super passionate with sharing this with everybody because you just don't know what's lurking beneath the surface until you take a good look. The good news is, like I was saying earlier, is if findings, they're all fixable. So it's no big deal. It's not a death sentence. It's not anything that's catastrophic. It's not like some horrible cancer diagnosis where more than likely you're going to have to get sicker before you get better. This is easy. Oftentimes it's diet and lifestyle change. And we all know that diet and lifestyle are impacting our cardiovascular health. That's nothing new. It's earth shattering or shocking. But sometimes this test is sort of the kick in the pants to just do a little better and actually really pay attention to what's going in your mouth, really knuckle down and grab like a carb counting app and really focus on what your carb intake is. I always thought I was eating super healthy, and Dr. Brew was like, why don't you check out what you're really eating? So I did, and I educated myself. One of my favorite fruits was a pear. I didn't realize that pears were loaded with carbs. I don't eat pears anymore. Little things like that. So sometimes diet and exercise, after you're seeing your CIMT results, you get a little bit more motivated to do a little bit better. Sometimes for someone like myself, it was a pharmacological intervention. They did immediately put me on a statin to help stabilize that plaque. I'm not going to get into the argument. Some people don't like statins. Some people do. For me, it was a personal choice of if I could take a little pill that could prevent me from having a heart attack or stroke. And thankfully I had zero side effects. I will take that low dose statin. Thank you very much, because I don't want to be at risk for having a heart attack or stroke. And super, super rarely is it a surgical intervention. Only about, I don't even remember the percentage, but it's a very small percentage of people that have the CIMT done are actually a surgical candidate. And the reason for that is in order for them to even think about cutting, you have to be more than 70% blocked. They won't even think about cutting until then. And so by the time you get to be that much of a restriction in your blood flow, you're probably going to start to be feeling some symptoms. So the CIMT is not something that's going to pick up, for the most part, surgical candidates. Most of those people are already under the care of a cardiologist. This is looking at the folks that are asymptomatic, like me, that had no clue. And if you look at the pie chart, there's 85% of us are walking around with risk factors, having no idea that we're at risk, me included. That's why heart attacks and strokes are the number 1 and number 4 killers of people, because there's no risk factors. This, however, the CIMT scan arms you with the knowledge that there's a challenge. And as long as you know that there's something that needs to be fixed, you can fix it. It's easy.
Ariana, that was actually the big impact of the Cafe de Cave study. It showed that there is a group, which we knew even beforehand, that people that had their flow clogged were at risk. But what we didn't know was people that even had no flow impact, but had small amounts of plaque, had significant risk, as you've just described. Not only did the Cafe de Cave study show that, it also showed we can find that. It's not that we cannot.
Yeah, that study was amazing. It really allowed the researchers, because the patients agreed to not seek treatment, it allowed the researchers to show what numbers are important. Where does it become scary? What numbers equate to heart attacks and strokes? What numbers don't necessarily matter? And between that and the Honda study of showing that the more calcified plaque is much more stable and the chances of it rupturing are very, very low, between those two, it really proved the efficacy of a CIMT scan. And if it's something that's so simple and it's painless, non-invasive, no needles, no disrobing, and it can, with the accuracy of 98%, predict your risk for heart attack or stroke, why would you not do it? I mean, to me, it's a no-brainer. So 20 minutes could save your life. I know for sure it saved mine. And I always joke around with people that say, whenever I meet them, I say, your butt, my chair, let's go. I want to be able to prevent people from having their families destroyed, from heart attacks, from strokes. I don't want someone to lose their mom, for someone to lose their dad or their brother or their coworker, or even just a really great friend. I had that happen to me actually just very recently. I had a very dear friend of mine who I did his CIMT scan He had some questions about it, so he showed me his report. And I told him that he needed to go see his cardiologist because there were some risk factors in there. He had some soft plaque. He also had a bunch of other kind of knocks against him for cardiovascular health, meaning he's Native American, so they're already, just due to their heritage, in a higher risk bracket. He has type 1 diabetes, so there's another huge risk factor bracket. Had high blood pressure and oftentimes would forget to take his medication, another huge risk factor. Anyway, long story short, this friend of mine took it to his PCP. The PCP didn't really know what to do with it. He never even got the chance to get to his cardiologist because he had a massive stroke in the interim. This test showed that he was at risk. And it's a very sad story because it would have been 100% avoidable had he been able to seek treatment prior. So everybody, your butt, my chair, let's go.
You thought I was going to say something, didn't you?
I did. That's why I stopped.
So I'm responding to some of the comments that are going on here. I think there's a lot of frustration that Medicare doesn't pay for this. I would agree.
Yep.
There was another one, a Canadian saying, "Oh, my doc here in Canada is never going to approve that," and I'm saying, "Hey, you know what? If the rest of us paid for our own tests, I mean, we're talking $100 to $300. The most I've ever seen paid for one of these was like $400. And the bottom line is, if you're waiting for your insurance company or your worse yet, your government to agree to approve the payment for this, it's like you're saying, okay, your government's going to, I mean, you're putting this is your life we're talking about here. And another comment has to do with, putting stuff in all caps. They said that you were a CIMT trained tech, trained by Todd, putting it in all caps. Then he apologized, and I said, "You know what? I'm an old man too. Yeah, I do that all the time. I live on I do telemedicine or YouTube all day, and I still can't get technology. It's just a constant source of entertainment." So, and the other thing I have to say, and I'll hand it back, I'll transition back to what you're talking about. I was wanting to make sure that we covered the Honda study. And sure enough, guess what's coming up?
Soft plaque, hard plaque.
The Honda study. So go ahead.
So this was actually a really cool study as well. The pictures that are up on the screen right now look at what I'd look at. It's a CIMT scan. So it's looking at the lining of the wall. And the blue line, so it's CIMT again, is carotid intima media thickness. And so if you really want to forgive me for 1 second, I'm going to get geeky on you. So you've got your intima, which is where your blood goes through. The media, which is the next lining down, which would be the red with the little arrows where it says CCA and ICA and all those little arrows. That first red line there is the intima media lining. And then it goes to the media and then the adventitia. And the adventitia is the outside of the wall, if you will. That's only one cell layer thick. So you've got the intima media and then the media adventitia. Those are the two walls, if you will, that we're looking at to take the measurement in between. And the Honda study looked at, okay, so what's the difference now about, how does it matter if it's hard, if it's soft, if it's squishy, if it's in between, does it matter? Yes. So the image on the left is a soft plaque or soft-er. It's actually probably, if I were to look at that, I would think it's probably heterogeneous because there is a little bit of calcium in there that your body is starting to heal. And when your body lays down calcium, it's how your body heals to that pimple. And everybody's body heals differently, but that laying of the calcium is your body healing to that injury or that inflammation. And so if it was completely soft, there wouldn't be any white flicks in there at all. And that's the tricky part. Soft plaque is very, very difficult to see on an ultrasound. And we do use Doppler to help us with that. Like what Dr. Brewer was talking about earlier, you put the color on, and if there's a soft plaque in there, no matter what you do, the color will not fill in that area because there is a very soft plaque that is blocking the blood flow. And what the Doppler looks at is it's bouncing off your red blood cells. So if there's an area that stays always blank, there's no red blood cells there. There's an inflammation. So As the plaque calcifies, it shifts towards the one on the right, which is calcified. See how it's all like white and kind of shiny and pretty looking? That's a calcified plaque. And the chances of that rupturing are very, very low. If you think of it, again, going back to the analogy of your skin, if you think of it as a whitehead pimple versus a cyst, a whitehead pimple, teenage acne, those things rupture all the time. That's bad. You don't want teenage acne in your arteries. The one on the right is more of a cyst, and the chances of that rupturing, again, very, very low. And I'm going to age myself a bit here and bring up Tim Russert, which I know Dr. Brewer's talked about prior in the past. Tim Russert was a news broadcaster that was on the air. I don't remember which news channel he was on, but anyway, he went through this whole, sorry?
Meet the Press, and I'm glad you're telling that story, because are you going to tell what the pathologist said?
Yes. Yes.
Okay.
Yep. So he did this whole on-air cardiovascular health, workup where he did stress tests, and they had him running around like EKGs and echocardiograms, and I don't remember all the details of all the tests because I was really young during this. But they passed him with flying colors, said he was a totally healthy individual. Like, way to go, good job, Tim Russert. I think it was like 3 to 6 weeks later, he dropped dead on air of a heart attack. And everybody was kind of aghast at this, like, oh my gosh, he just went through all this testing and they said he was healthy. And then they did his autopsy. And when they dissected out his carotid arteries, the pathologist said that his carotid arteries looked like a teenager's face with acne. It was loaded with soft, squishy, gross plaque. So although he had passed all those other tests, he didn't have a CIMT. I don't think they were available at that point in time, or at least not readily available like they are now. And had he had a CIMT test done, they would have picked up those soft plaques and he would have been able to seek treatment. So the Honda study is important, as well as the Caffey caves. We need to make sure that if you have plaque, you get them stabilized.
Let me just say one other thing. As usual, Jesus didn't include all the good parts here. If you go to the other components of that Honda study, so basically what Honda did was he did a life table analysis of people with plaques like you see on the left, which is very accurately described by Ariana. Those are the pimples that they saw in Tim Russert's arteries after he died. If you look at the ones on the left, they took about the Honda study took about 100 people with that kind of plaque, and then they took about 100 people with the ones on the right. And they showed a couple of things. Number one, this by looking at it now. It's not people making it up. There's no subjectivity. They did optical character recognition, and they looked at the scores and differentiated these two populations based on the amount of calcium in the plaque. The folks with low plaque continue to have heart attacks and strokes in their population. The folks in the population with calcium did not. They stabilized, and their event rate was very similar to someone without plaque.
I want to jump in here too for 1 second, Dr. Brewer, because I'm sure this is something that you see often with your patients. A lot of people go get a CIC score because cardiologists seem to like that one a little bit better than CIMT scores. And oftentimes they freak out because their CIC score is high. And I want to just tie it back to the Honda study that even if you have a lot of calcified plaque, as long as it's not impeding your blood flow, it's actually way safer for you to have that plaque completely calcified than to have it soft and squishy and risk it rupturing. So a high CAC score isn't necessarily a bad thing. It means that your plaque is stable and is more like a cyst, and the risk of it rupturing is very, very low. I'm sure Dr. Brewer can, jump in and talk about more of the details of that. But I just want to caution people that a high CAC score isn't necessarily a bad thing.
If you don't mind, I will jump in. Oh, you know what? I spoke too soon. Jesus does have that. So that's the dotted line is the people. Every time you drop, there's an event, a heart attack or stroke. The dotted line is the people with the calcium, and the solid line is the people that had soft plaque. So like one event on that stabilization period in the very beginning, and then a great experience compared to a very not great experience. To your point that you just brought up, Ariana, about these people with really, really high calcium scores, Jesus did some great work. I had never seen this before, but he found some very clear evidence that these people come in with 1,000 or more, or more often people like we've seen. I mean, from my own experience, it was very clear. Most of these people that have 1,000 or more are really people that have figured out they had problems, lost 30 pounds, lost 100 pounds, and really reversed their risk. Unfortunately, the population doesn't understand that, and clearly the docs don't understand it either. That and nobody understands it unless they do what you do in terms of actually following plaque. When plaque is healing and stabilizing, as shown in that those last life study analyses from the Honda study, when plaque stabilizes, it calcifies, and people are in good shape as opposed to bad. So we get people coming in all the time. I'm a dead man walking. I've got a calcium score of 2,000. Most of those people we find are actually in really, really good shape compared to what they were just 3 years ago.
Yeah, and that's the misconception, is that people kind of freak out. And so what's on the screen now is an example of a cardio risk report. This is what you'll get after you come see me. So the one thing that I like to kind of caution people about too is the patient age versus the arterial age, because it's the very first thing that you see. And oftentimes patients freak out and they go, oh my God, I'm 85 years old, according to my arterial age, but I'm only 50. Okay, well, first of all, again, take a deep breath because stress is bad for your heart. And what I want to explain to you is the patient age and the arterial age. The way that obviously your patient age, they know because your birth date. Your arterial age is calculated by CardioRisk does 600 points of measurements that are all within the accuracy of a third of the width of the hair on your head. So 0.002 millimeters, very, very accurate. And that's important because when it comes to something as small as your carotid artery, and the difference between a diseased artery and a healthy artery is only 1.3 millimeters, you need that measurement to be pretty darn accurate. So that's why it is super important that if you have a CIMT test done, that the software that's doing the reads is accurate and very, very accurate. So your arterial age, back to that, how that's calculated, is CardioRisk does over these 600 points of measurements, and your arterial age is based upon the average of those 600 measurements, which on this chart is the average CCA mean IMT. And what that stands for is average common carotid and then your mean intima media thickness. So it takes all 600 of those measurements and it averages them out. It sticks them into this huge database based upon your age and your gender, and it figures out where you are in your arterial age. What I want people to remember is take a deep breath, because inflammation is completely reversible. So even if your arterial age is 85 now and you really knuckle down and make some, hard choices and really pay strong attention to what goes in your mouth and actually work out and do the things you're supposed to do, like Dr. Brewer tells you all the time, the HIIT training and low carb diet, all those things, you can reverse the inflammation and your arterial age will come back down. So take a deep breath. That's not the really important part. What I want you to pay most attention to is at the bottom of the screen here where it says plaque burden. Oop, wait, he just moved. Your plaque burden, again, anytime you have any plaque whatsoever, and a plaque is just a large inflammation, once it reaches 1.3 millimeters or larger, it qualifies as a plaque. Anytime you have any plaque whatsoever, it will automatically put you in the high risk bracket, because again, you simply having plaque puts you in a higher risk bracket than someone that has no plaque. So don't panic about that either. Just because you have plaque doesn't mean you're dying, doesn't mean you're having a heart attack or a stroke. What the most important is in this teeny tiny little comment section that comes on the report where it says write CCA 0.8 bulb 1.4H, which stands for heterogeneous. And if you see the plaque burden was 1.4, so they only had one plaque that was found in their right bulb, which is very normal, by the way, and I'll get back to that in a second. And it's already heterogeneous. So that means your body is already starting to lay down calcium over the top. It's already starting to calcify it, stabilize it, heal it. So the chances of that rupturing versus a soft plaque is very, very low. So what I want everybody to pay attention to is don't get caught up in the kind of, I don't want to say tricks because that's a bad word, but the fear factor that comes from looking at your age, your arterial age, that is all fixable. It's all inflammation and it's reversible. Pay more attention to your plaque burden. And if there is a letter S after that measurement, that's when you need to be much more concerned because those are the most unstable and you are at a much higher risk to having a heart attack or stroke. Once it says H or even better E, which stands for echogenic, echogenic plaques are completely calcified. There's no soft squishy stuff left in there at all. It's like a little boulder in your neck. And the chances of that rupturing are extremely low, like almost probably zero. That's probably stretching things, but the chances of that rupturing are very, very low. What I was talking about.
So, Ariana, I had sent Jesus a text while you were talking, and there were some questions about how to read these things. And I said, go ahead and just pull mine and plop it up there. That is mine. That's mine from Tampa, isn't it?
I think so.
And so just so folks know, my first CIMT, I don't know if we have that or if we have it available. I was 57 years old and the arterial age was like 73, 74. And I was not obese at the time. I didn't lose 30 something pounds, but I did do a few things. I did lose about 8 more pounds. I did, and the statin haters are going to not like this. And I'm going to use that phrase. I could get banned for saying this. I don't think I will. But I started statins. I started a low dose statin. I ran, as you have mentioned in several places, there was still a lot of stuff more that I could do, like adding HIIT training back into my workout, further decreasing carbs, significant decrease there. So it wasn't a whole lot, but you put them all together, and then in a short time period, I went from a 57-year-old with 73-year-old arteries to a 58, 59-year-old with 55-year-old arteries, 56, something like that. That was years ago, and I've maintained that low arterial age. Now I'm going to say Ariana has been trained by some of the best, Todd, and some of the best groups in the world for looking at arterial age. I would suggest strongly that you don't get too wrapped up in arterial age because it's the hardest thing to look at. Look at the things that Ariana's been talking about. It's whether or not you have plaque, number one. And yes, we know I have plaque. But number two, then, is it soft, heterogeneous, or echogenic? And Ariana and I both, or Ariana and I, are not in 100% agreement. I would say that the heterogeneous is probably 80 to 90% there in terms of stability. I think Ariana would say closer to 50.
Yeah, I'd go 60-ish. Yeah.
And I would say higher amount. I see a lot of patients that just never get to echogenic, and I'm one. Even though I've been 10 years into this process, and I've clearly had improvements in labs, and actually, implied improvements from arterial age, still have not gotten to echogenic.
And you're not alone. There's a lot of people's bodies that, for whatever reason, never reach the echogenic stage. And there is some research that I hear whispers about that they're doing. They're starting to find a study as to why. Why is it that some people's bodies never get past this heterogeneous stage? I'm not sure if that research is ever going to get off the ground or not. But regardless, there is also, I'll just geek out a little bit here. So for my CME credits, I had to read a research paper, and it was looking at the actual consistencies of the various I guess, hardnesses of heterogeneous plaque, because there's obviously a scale, it goes from soft and squishy to completely echogenic, and there's a range in between. And that whole range in between is considered heterogeneous. But some research group wanted to find out, well, where is the difference between the heterogeneous? And that's why, Dr. Brewer and I love to disagree on, how stable is heterogeneous plaque. And I think it depends really on where in the stage is it? Like I said, some people's plaque will never get to the echogenic stage, but those plaques that are kind of barely past the soft phase, sort of like the picture in the Honda study, that it's certainly not a soft plaque anymore. There's calcium in there. You can see the little flicks of white, but it's obviously not completely calcified like the one on the right, where it would be considered echogenic. And they did this bubble study where they injected microbubbles, and it was able to literally delineate the different types of heterogeneous plaques. And I think that's a really cool study that just because the geek in me wants to know, if we follow that line of thought process, where does it, where in the heterogeneous does the challenge become less of a risk? And so that's where Dr. Brewer and I love to disagree. But back to the plaque and the bulb, that is kind of the norm, if you will, of where we see plaques begin from the people that I've scanned anyway. And I think it's just a simple matter of physics. Your blood comes up through your common carotid, it hits the bulb or the bifurcation, which is just a fancy word for split. And it has to decide, your blood then goes into a Y like this. And it goes into your internal and your external carotid. And it hits that bulb, and there's just, due to physics, a tremendous amount of turbidity in the bulb. So the blood's kind of smashing into the walls, and it's trying to decide, am I going internal, external? Where am I going? And because of that turbidity and smacking into the wall, we often see inflammation and plaque start in the bulb, because that one cell lining, thick lining of the wall is taking kind of a physical beating of the blood smacking into it. And life happens, and we all start to get nicks, cuts, and tears in the lining of that wall. And the more nicks, cuts, and tears that get in the lining of the wall, more stuff gets stuck. Like what Dr. Brewer always talks about, like LP(a), the small cell cholesterols, the proteins, the lipids, the fats, all of the stuff that Dr. Brewer can go into way more detail than I can. But all of that bad stuff gets stuck in the lining of the wall. And the more nicks, cuts, and tears you get, the more stuff gets stuck. And the more stuff gets stuck, the more spread out it gets, and it becomes a snowball effect. So that's why it's pretty common to see the inflammation and the plaque starting in the bulb.
I have to interject already. It's 45 minutes in. Dr. Brewer is more concerned now about answering questions on the chat than actually doing the show, and it's pissing me off. Because Dr. Brewer, you were pushing me into showing your chart, and you're not even talking about your chart as you're supposed to.
I did. I covered the whole thing.
Awfully. People are not understanding these numbers that you see right here are measurements on millimeters. So you can actually track the size of the plaque and the type. So that's important. So that's why you should have a CIMT every year. The next part is, Dr. Brewer, I appreciate all of our viewers. I love you all. But this is my role in here. If you're not a member, just like Getro, perfect. You should not be getting a quick answer. You have members asking questions.
And that's why you're upset right there.
So I'm taking care of my members.
There you go.
You probably don't care. I do.
That's your role. I got caught red-handed. I'll quit.
And the other thing that I'm a little bit mad about is you're not showing. Let me see if I can put it on the screen. Heather has been here the whole show.
That's the other thing. What was I supposed to introduce Heather? At first, I wondered why Heather wasn't there, because I know she was ready to attend.
Yeah, I've been sitting backstage like Dr. Vega has.
So wait a minute. Who's organizing this thing anyway?
You are. You know.
No, I'm not organizing it. You're the channel manager. I told Ariana that all these things started happening when we got our new channel manager.
So I'm going to go. I mean, I appreciate, I think this is really good. I wanted to keep it under an hour. I'm not going to be able because I want to address a couple of questions from members. So if you have more questions about it, shoot it on the chat and preferably become a member. Now, before we go to questions and answers, I want to show you this. I know that the letters are really, really small. So if you are a YouTube member, and Gilbert, please show them how to become a member. Click on the join button right there. The main perk is I want to make sure you get your questions answered if you're a member. If you're not a member and Dr. Brewer gets off rails and starts answering, well, there's just so much I can do about it. But if we're not able to get your questions during the show, what we're doing right now is there are two types of memberships, standard and premium. If you become a premium member, which is only a couple of bucks a month, we're going to be doing our best to answer your questions in any of the videos. Like, for example, if you go back and look for the video, how I reversed 20 years of arterial plaque, or how I reversed my plaque in 1 year from Dr. Brewer, going to the, you can see all the images from all the CIMTs of Dr. Brewer has had in that video. Go to the comments. If you have a question, go ahead and ask a question. If you are a premium member, I'm going to make sure that either Dr. Brewer or myself, we're going to do a small short video for you with an answer.
Oh, that's the other thing.
And that video is going to be available only for members, either standard or premium members. So premium members get their questions answered with a video. Standard and premium members will have that exclusive content just for you. So become a member. And the other perk is no answer for you if you're not a member on the live chat, unless Dr. Brewer starts misbehaving.
And for those of you who are wondering about the back and forth with Jesus and me, we understand there's clearly tension here. His job is to manage the channel, and it is to protect the members. My job and my desire is to help people, no matter who they are, and that's what I'll end up doing. So,
Dr. Brewer, these people are putting some bucks up front for you.
Yeah. Now, one of the if you're
I'm not really mad though.
I know. and I want folks to know that too. And one of the comments that came up, I did, as I often do, I pushed our own people. One of the folks is asking me, what do you do? How do you reverse cardiovascular inflammation? And I'm going to ask Heather to go through that in just a minute. But before we do, I said, you know what? Call my office, 859-721-1414, and tell them, number one, ask them where to get a CIMT. But number two, ask them to give you a free copy of the cardiovascular inflammation course. And number three, ask them to give you a widget. And then Jesus is texting me saying, but the widgets aren't ready. That's true. I don't think the widgets are quite ready, but tell them, push them a little bit and say, Ford said, as soon as the widgets are available, please send me one for free. The widget is one of the ways that we help people begin to understand, without having to go see a cardiologist that doesn't understand this, or another doc that doesn't understand this, in the comfort of your own home. Are you at risk for cardiovascular inflammation? Now, are we okay with Heather taking a few minutes and describing cardiovascular inflammation, what it is, and what to do about it?
Yeah, well, I know you need my permission for about your stuff on YouTube, but Heather, it's on you. You go ahead.
Well, so, if you were wanting to go somewhere else, I could say we could wait.
Yeah.
No. I'm okay, Heather. I think that's very important for people to understand cardiovascular inflammation. Go ahead.
So the CIMT is one of the many, one of the things that we would check to evaluate your cardiovascular risk and inflammation. But we also do a pretty detailed lab panel as well. But for us, lifestyle is king above anything else. Lifestyle including dietary changes, all forms of exercise, because I've seen a lot of comments about exercise and being stressful, and also comments about foods like fruits and vegetables are supposed to be low carb, and then maintaining a healthy weight. But regarding foods, one of the things that we recommend is everybody's body responds to foods differently. So one of the things that we recommend is wearing a continuous glucose monitor and see how you as an individual respond to the foods that you eat. And then it's a great learning tool for our patients. They learn a lot about their bodies. For example, I've had patients tell me that the berries are typically a lower glycemic carbohydrate as far as fruits go. But I've had some patients say, you know, I can't have blueberries because when I ate blueberries, it spiked my blood sugar too much. So they stick to the blackberries or the raspberries, strawberries. So it's a great learning tool, and you're able to make those dietary changes based off of how your body responds to those foods. And also, as far as exercise, there's aerobic, anaerobic exercise. We're really big on resistance training. Working the larger muscles of the body because that's your number one safety valve in regards to insulin resistance, pre-diabetes, diabetes. Also re-hit or hit, reduced exertion, high intensity training for 20-second intervals, or a minute interval on the hit exercising, and then walking, cycling, just your basic aerobic type exercise. So really for us, lifestyle is what we educate about first. Yes, low dose statins as little as 3 times a week, a 5 milligram Crestor can help reduce cardiovascular inflammation and help heal and stabilize that soft plaque. But we don't push medications. It's more we educate patients, and ultimately those decisions are up to the patients. But we also evaluate, you know, a full lab panel. We look at cardiovascular inflammation markers. We look at your lipid panel and fractionation of the lipid panel. We look at thyroid function. There's all kinds of labs that we look at, the oral glucose tolerance test with insulin response. So, and then obviously the CIMT, you know, to be the diagnostic imaging. I hope that helped somewhat.
Really good. Way better than Dr. Berg. He hasn't been able to explain like that in 2,000 videos. So really good.
That's why I keep trying. I just maybe one day I'll get there.
Yeah, just kidding. So thank you so much, Tracy. And I'm gonna take as many questions from members as I can because we're close to the end, and oh man, we have a bunch of questions. So I'm sorry if I wasn't able to address all of our members' questions. That's Dr. Brew's fault.
Yeah.
So trial that I think you're a new member, aren't you? I haven't seen questions from you before. I just heard Dr. Saiva say smokers show plaque all over and carb addicts only show plaque in their arteries. I guess I'll find out next week because I've never smoked cigarettes. Well, let us know. Keep us updated. I think bottom line, smoking is just radioactive. Don't do it.
And I will say this, Jesus, you know, it's part of the CIMT science and evidence. It's really clear because one of the questions people have is, well, wait a minute, you're looking at my neck. What I want to know is about my heart. The reality is it's less than 2%. It's already been, again, studied. If you have plaque in one arterial bed, 98% plus probability that you have it somewhere else.
Yep.
Wonderful.
And it's not criticism of Dr. Saiva. He's a good buddy, and he and the three of us have done a lot of videos together. The other folks in the low carb community, as we're getting to know them better, have all admitted, hey, you guys really go deep into plaque. We just haven't really studied that much. It's a good point.
Yep. Regardless, refined products, refined carbs, smoking, it's just a no-no. Rick Folia, I wish you would create a presentation that strongly encourages this and take it to the road to present at conferences. So some people do that. Our friend David Mines is all over the place doing that. And you just did an interview for PBS at Dallas, right? And they're going to be doing that. If you have PBS, access to PBS network, check it out.
The old public broadcasting systems. It's still alive and well.
Wonderful. Woody Woodring, I'm gonna write our email info@PrepMedHealth, and you are a member. So anytime you have a proposal for a topic, put it on the chat. I'll write it down and I put it on the list. So we can do that for you. Joe is saying hi to Ariana.
Aw.
I just met him last month.
Yeah, Bob Bell is touching a really good something that I'm a bit passionate about too.
Yep.
I would definitely prefer Clearly over CIMT. My Clearly gives me the detailed quantitative and phenotype data. The CIMT is less detailed and specific. So I'm gonna just kind of refer to one comment that Ariana said about CIMT is the only way to find soft plaque, the only non-invasive, cheap way to find soft plaque.
Yeah.
And if you want to have a Clearly scan, which is you go into the cath lab, they put a needle on your groin artery or on your arm, they inject a dye on it, and then you have to go to the CT machine, get a little bit of radiation. I love the Clearly technology. It will show you the heart, the arteries, and the AI machine is going to give you the readings on how much soft plaque you have. That's fantastic. Downside, if it's not covered by insurance, it's going to cost you a lot of money, both the CT scan and the interpretation. And still, you're going to have to go to the cath lab, maybe take some medication to slow down your heart rhythm and to get the testing. So if that's available for you, I'll Clearly, pun intended, will do it. I know Dr. Brewer is planning on having his. If you want to see the Nikki detail on the coronary arteries of your heart, that's the one to go to. But if you don't want to go through all of that effort and you have a CIMT nearby, which is cheaper, no need a prescription, and you can have it with an ultrasound, which doesn't involve radiation, I'll do CIMT. I'll personally will do both. I'll do a CIMT every year and a Clearly scan every 5 years.
And for people like me that are allergic to contrast dye, I can't have it Clearly. So the CIMT is the only option for me. And it gives me the same amount of risk. It still gives me the same answer, gets me to the same endpoint. The Clearly gives you more detailed information, but the end result of telling you your risk factors are going to be pretty much the same.
Wonderful. Trial that I'm 65 male with 2 stents, 50 months keto with good numbers and lost 70 pounds. Congratulations.
Amazing.
It is wise to treat inflammation with colchicine and track the CIMT, or I'm a coding disaster. Oh man, how many people have you seen lose weight? The CAC score goes up and the cardiologist says, you're about to die. You're about to have a heart attack.
Yep.
But I want to recover the colchicine question because we have covered colchicine before, and I think we should do that maybe next month.
I agree.
Thoughts on colchicine?
A lot's changed in the world. What's the name of the guy at Harvard who did the colchicine study? He's doing all those inflammation studies.
He's the one who did the first study on CRP, isn't he?
Yeah. Now, if it was me doing that, Jesus, you would say it's the statins or my age talking. You're not on statins and you're not old like me. Why can't you remember?
Well, I can blame that on genetics as you do.
Okay.
Paul Ridker.
Yeah. Paul Ridker and Gavin Blake were the guys that did the original cardiovascular inflammation studies. And Paul Ridker was the one that did some studies looking at colchicine. He did see a positive impact on cardiovascular inflammation, but colchicine's been used for a long time. It's really rough on the GI system. What they're doing now is, and we knew, given those results, that the story was not over for colchicine, and surely it wasn't. They've started looking at low dose colchicine. So I agree with you. It's a big development in the field. We do need to cover.
Definitely. Heather or Dr. Brewer, do you want to answer Joe? If you're on a low carb or keto, should you monitor uric acid blood level?
Go ahead, Heather.
I mean, we do. We monitor it.
Yeah, and we see some people that if they eat more meat, the uric acid can go higher. But we see more people having that problem when they are ingesting fructose, especially from processed foods, and sometimes fructose from some fruits. But that happens less often unless they really are binging on some specific fruits.
Right. Agreed.
Bob Bell says he had his first Clearly. It was covered. Now they don't wanna cover the second one because he no longer has symptoms. And that's the problem with the Clearly scan as well. I forgot to mention. Depends on who interprets the results. Because usually what's going to happen, just like a traditional CT angiogram, some people will interpret that and say, okay, there you go, directly to the cath lab and get a stent. And we do have a perspective on stents. Dr. Bruce just said they don't prevent heart attacks. There's evidence, especially on the Orbita trial and the Orbita 2 trial, that people with angina, chest pain, might benefit from a stent for decrease the chest pain and even improve their ability to exercise. But other than that, it's not like you're going to have a stent and you're free of risk. That's the big danger of a stent. And clearly, scans can lead you there if you don't have the proper information. Rick Folia, you're right. CT angiograms also show soft plaque. And Bob Bell, yeah, low-dose statin can help stabilize plaque, definitely. All right. Libalo, less troublesome in my experience. Would you agree, Dr. Brewer, Heather? Libalo better than other statins?
For those that have had previously been on really high dose of statins, I'm talking 20, 40 milligrams, and have had side effects, we usually will try to get them to consider low dose Crestor 5 milligrams, just like 3 times a week, because that has a really long half-life. However, even some patients can't even tolerate that. So we will do Livalo or pitavastatin. It's the lowest dose statin at 1 milligram. And
pitavastatin, the downside for pitavastatin is that it's very expensive compared to the other ones. It has not lost its patent yet. And they also know another upside is it's not very much linked to any of the side effects, including the most common and worst one, and that is pushing patients down that insulin resistance highway.
Yeah. And I would like to go back to the last comment. Bob Bell, I think you're right. Our medical system is not geared to prevention. Maybe that's why heart attacks and strokes are not really being prevented as well as they should have. How many preventive medicine specialists are in the U.S., Dr. Brewer? Or like the percentage of total specialists?
I was going to say, I don't know the number, but, I used to run the prevention program at Johns Hopkins. And as part of that, we looked at manpower. And it wasn't 5 in 100. It wasn't 10 in 100. It wasn't 2 in 100. It was 1 in 200 or 1 in 300. Medical school graduates did go on into prevention.
Like 0.5% then?
Yeah, 0.5%. But that's not the worst part. The worst part was the vast majority of those people went into government work and became bureaucrats and went to work at the health department. You know the story. It's the same things happen in Mexico with you. They end up going into other bureaucratic type positions. It's less than 1 in 10 out of that 0.5% actually go into doing what we do, actually helping people reverse their heart attack and stroke risk.
And then you have family medicine doctors, general practitioners, cardiologists who they are floated with patients that already have the disease.
Yes.
So they can't do prevention either.
No, we don't have that. I mean, I was primary care. There's limited time. It's unfortunate. It really is.
And it is a specialty with acknowledged specialty information. And unfortunately, it's done by people that don't have the training. So that's why you turn around and you see plenty of studies, plenty of evidence from Hopkins, Mayo, and other places indicating the docs that we rely on to do prevention. That's going to be your family practitioners, internists, and cardiologists for the most part. 3/4 of them don't even know how to diagnose prediabetes.
Yep. And the last part, just to close this, Dr. Brewer, you are sometimes a little bit you're not polite enough. Thank you so much, Ariana, for spending the time to be with us. You did a great job.
Yes.
You should be the host of the channel now.
I thought we were doing great until Jesus barged in.
I have to keep the things on track. And the last thing is, if we didn't,
it's way beyond an hour, so you failed there too.
I know I was going to take the blame for that one. So if you are a member and we didn't get to your question on the chat, I apologize. It's Dr. Brewer's fault. But if you have a question, go visit any of our videos or even this one comment your question. We'll do our best to give you an answer with a video that is going to be exclusive to all channel members, not YouTube Premium, channel members. So you have to click on join. If you're a standard member, you're going to have access to those exclusive videos. If you're a premium member, we're going to do our best to answer your questions. We haven't put a limit on how many questions, but I mean, we're going to be reasonable. I mean, if you ask us 10 questions in a month, we're probably not going to be able to answer all of them. But if you have one or two, we will do our best.
David Mines is saying he's a member, but you know, David's really special with the group. We might not answer his question.
Oh, David already knows the answers.
Yes, he
That's
does.
true. He doesn't need us to answer.
Ariana, you did so great. Thank you so much. I always learn from
Thanks.
you every time, you know, I'm around you. So I'm glad to see you again too.
Oh, thanks, Heather. It was great seeing you too.
Yeah.
And
You're
of
an
course,
excellent-
the only one who hasn't showed appreciation is Dr. Brewer. I'm just waiting for him.
I was gonna say that, you know, there's a reason why we had Ariana back. She's a great speaker.
Yes.
She, you know, unlike most people, she didn't freeze in front of the camera, and she does a great job at communicating what's going on with CIMT.
Thank you.
And I'm going to give some credit to Dr. Brewer. Rose held, so subs are plebs. No, not at all. And Dr. Brewer is pretty much keen on that, and we appreciate you a lot. Just want you to consider, if you're into a YouTube channel, we're trying to provide all this information for free, and we appreciate you being a subscriber. Then there is a subgroup who is giving some extra money just to support the channel, so we want to show extra appreciation for them. So if you're a subscriber, we love you. Well, thank you for watching. I hope you can see this information as useful. If you're a YouTube channel member, we need to give away a little bit more for you. So that's just how the way it works. We love all of subscribers as well. And we love even our viewers who are not subscribed. If you're not subscribed, that's okay. We love you anyway. We appreciate you being here.
Mm-hmm.
So Rose is asking, is the phone number for members only? And the answer is no. Go ahead and you can call the number.
Yep.
Yeah, absolutely. Thank you for clarifying. And that's what comes with being a part of a YouTube manager. There's some stuff that you need to take care of. So,
And Paulette's wanting to know how to become a member.
yeah. So Gilbert, can you put that on the screen right away, real quick?
There we go.
So just go into where it says Dr. Brewer, and there's a button that says join. And then you're going to have two options, standard or premium. If you want to support the channel that way, go ahead, do it. We appreciate it. If you don't, you want to be a subscriber, go ahead, be a subscriber. If you didn't like any of this, go ahead and find the person you hate the most and share that video with that person. So you're going to make them waste some of their time. Yeah, they will waste their time with that. All right. Well,
and do a thumbs down.
Oh, yeah, do a thumbs down. Absolutely. All right.
Thank you. Thank you again. Thank you, Jesus. Thank you, Heather. And thank you especially, Ariana.
Yes, thank you.
Thanks for having me again, guys.
Finally.